for joining us today. Welcome to the webinar on engaging non-state actors in governing health, the key to improving quality of care. Non-state actors have the potential to contribute to governing quality, from providing technical inputs in policy development and monitoring health service delivery to promoting accountability in the health system. However, they are often not effectively involved in achieving the national health agenda, particularly the universal health coverage. This webinar is a continuation of USAID's Health Finance and Governance Project efforts to promote various governance mechanisms to improve quality of care. This also builds on the Joint Learning Network's technical work on improving quality and engaging private sector in achieving universal health coverage. Next slide, please. Now let's take a look at today's agenda. Dr. Carlos Correa of Audits Associates will frame the issues and identify various strategies in engaging non-state actors in governing quality of healthcare. Then we will deep dive into 3 of those strategies that he mentioned. The first is the use of regulatory instruments, particularly accreditation by a National Health Insurance Agency. We are waiting for Dr. Nat Otu, former CEO of NHIS, to share Ghana's experience in using accreditation. Engaging provider associations in governing quality of care is also another strategy. Dr. Raul Quillamor, a representative of Philippine Obstetrics and Gynecology Society to the Quality Assurance Committee of PhilHealth, the Philippines National Health Insurance Agency, will share his insights. Finally, Ms. Paulina Pacheco will share with us Mexico's more than 15 years of experience of capturing the collective voice of citizens in improving quality of care, called Aval Ciudadano. To share their insights and bringing us various expertise in this conversation, we have Dr. Carlos Correa, Vice President and Senior. Next slide, please. Let's, okay. Some WebEx Q&A and chat tips first. We believe that this webinar has resonated to many of us working in the health sector. So we would like to hear your thoughts, comments, and questions during the entire session. Please send them via the Q&A panel as shown in your screen and submit them at any time during the webinar. Our panelists will reply to them during the Q&A. We can have some clarificatory question in between presentations. You may also use the chat panel as shown on your screen to inform us of any technology problems that you may be experiencing. Please do not send your questions via the chat functionality as we might miss them. We will answer as many questions as possible. We are joined today by excellent speakers who are bringing with them expertise and various perspectives. Dr. Carlos Correa, Vice President and Senior Fellow at Audits Associates, is currently the Chief of Party for USAID's Jordan Communication Advocacy and Policy Project. Previously, he served as Portfolio Manager of the Clinical HIV/AIDS Services Strengthening Project in Mozambique. He joined Audits Associates in January 2001, working as Chief Party for the Primary Healthcare Initiatives and Health System Strengthening Projects in Jordan. Prior to joining Audits Associates, he was co-founder and executive director of ProSalud, a Bolivian NGO. Dr. Correa holds an MD from the Catholic University of Cordoba, Argentina, an MPH and a Diploma on Tropical Medicine from the Institute of Tropical Medicine at Antwerp in Belgium, and a Diploma in Management from NUR University, Santa Cruz, Bolivia. Mr. Nat Otu, former CEO of Ghana's National Health Insurance Agency, is currently an independent consultant. He has expertise in risk protection, social security, universal health coverage, and public sector reforms. At the NHIA, he was instrumental in the review of the National Health Insurance Scheme enabling law, which now addresses the administrative and legal challenges of the previous statute, including the transformation of the district mutual health insurance schemes to the National Health Insurance Scheme. Before entering the health financing sphere, Mr. Utu'u has over 20 years experience across the social security, manufacturing, and trade promotion sectors. He holds a master's degree in international relations from the International University of Japan, a Bachelor of Law from the University of Ghana, and professional qualification in law from the Ghana School of Law. He is also a very active member of the Joint Learning Network. Our third speaker is Dr. Raul Quillamor, the Head Executive Staff at the Office of the Chairperson and Secretary of Health at the Philippine Health Insurance Corporation, or PhilHealth. He's also an advisor to the Technical Working Group on Life Stage Package for the Pregnant Women for the Department of Health and PhilHealth, Vice President of the Philippine Society for Responsible Parenthood, and an auditor for the Academy of Medicine in the Philippines. He's the department chairperson for the Obstetrics and Gynecology Department at the University of the East from Magsaysay Memorial Medical Center. He finished his MD medical degree from the same university and completed his residency in obstetrics and gynecology from the same institution. He completed subspecialty fellowships at the University of the Philippines, Philippine General Hospital, and at Amagasaki Prefectural Hospital in Kobe, Japan. Our fourth speaker, Paulina Pacheco Estrello, is currently Director at the General Directorate for Quality of Health and Education within the Mexico's Ministry of Health. She is in charge of the interinstitutional entailment and follow-up to international agenda of quality in healthcare. Ms. Pacheco has 15 years of experience in the health sector. In the realm of public administration, she has served as division head at the Mexican Institute of Social Security and was Director of Equity Analysis at the Economic Analysis Unit of the Ministry of Health. She holds a degree in administration with specialization in strategy from the Instituto Tecnológico Autónomo de México and Master in Public Policy from the Universidad Iberoamericana. She also has expertise on social security for Spanish-speaking countries by the Postgraduate Institute of the Chinese Academy of Social Sciences. The other information about our speakers are available in the website. And I am Lizelle Lagrada Rumbawa, the moderator for this webinar. I am currently an independent consultant, but has more than 15 years of experience in government work, having worked as Municipal Health Officer, Chief of Health Planning at the Department of Health, and at various positions at the Philippine at PhilHealth. Okay, moving on. We are pleased to call on Dr. Cuellar to frame the questions, to frame the issues surrounding the engagement of non-state actors in pursuing quality of care. To you, Dr. Carla.
Okay, thank you. Thank you very much, Lizelle. Can you hear me well?
Yes, very well. Thank you.
Okay.
Go ahead.
Okay, thank you. Thank you very much, and thanks to all that are presenters, panelists, and attendees to this webinar. And that I understand that it's the continuation of a series of webinars that the Health Financing and Governance Project is promoting. As you said, I will frame the issues that are around engaging private sector in promoting quality of care. Can you go to the next slide, please? The focus of my presentation will be on two main points. Talk about what are the challenges to private sector engagement in governing quality of care in general, and also to focus on what is the role of governments in fostering not just quality but affordable care in the private sector. Next. First, I will start by saying that, as you all know and recognize, private health sector is not a homogeneous sector. It's very diverse. We can have from tertiary hospitals to pharmacies or faith-based clinics or just private providers that are delivering services across focusing on low and middle income countries. So first point, we have a diverse sector, so not all solutions fit into that, and but also we will recognize later on that it's a strength. Next. Same way, private sector is diverse, providers are diverse. There is no one type of provider, and as you know, we have doctors, nurses, nurse midwives, even traditional healers or pharmacists that are providing those services. Next. And in addition, private sector in most, not in all, but in most low and middle income countries is a significant actor in the market, and also is growing. It's growing in its importance in terms of the coverage, the reach that they can have on the population. So in this slide, as you see, it's one, I would say, clear example of the expansion of private sector provision of institutional delivery in Bangladesh. You will see, private sector marked in blue, number of deliveries have grown over the years, and in this particular case, it's having even more or doubling the public sector, and recognizing that in this case that home deliveries is the most prevalent side of delivery as opposed to institutional delivery. So it's just to show how important and it's private sector in most countries, more than in others, and it's a significant force that cannot be ignored. Thanks. In this slide, I try to summarize what are the kind of the main points that I believe are relevant for going to the issues that need to be analyzed in the webinar. The first one is the recognition that the private sector plays a large role in the health system and in different ways, from production or provision of care, financing, and not just services, but also products. So its diversity and the significance in the market is a strength, and obviously it gives the flexibility to deliver different type of services in different sites by different type of providers. But the most important point is that this is a strength, assuming that quality of care is present, and this has been historically, I would say, one of the main and recurrent complaints that governments talk about when they are referring to private sector. Next. So, what are the challenges to private sector engagement? Obviously, because of its size, because of its importance, it's very, it's a very pragmatic approach to engage them and to make them part of the solution, or to strengthen the health system. But what are the problems? So what are the challenges to engage private sector? The first, I would say the most important one, is the fact that private sector is in general unorganized. So it's individuals that some of them they are not active participants in professional associations, or they are not participants, of members of networks of providers, or social franchising, or other type of chains or groups. So they're limited. They have a limited voice and visibility, and for governments, it's very hard to engage them on a one-by-one basis. They need to, be organized. Other challenges is that private sector in general, they have limited access to quality improvement programs, training programs, and also even to finance sources. And therefore, because of these 2 points, it's not very unlikely, but at least it's chances of participating in health financing schemes that are linked to, say, universal health coverage or any health insurance scheme. Private sector has its limitations because of the requirements, some requirements that can vary from country to country on licensing, certification, accreditation, all the payment mechanisms and rates. I mean, the prices that are services are paid by these health insurance schemes are not based on their own costs, but based on standard costs. So government, providers and private sector can have problems to meet that. And besides all the administrative burden that represents being part of these schemes, and the fact that they have limited means to deal with this type of situation. Next, please. So, regarding quality of care, and I try to summarize and see with this with the lenses of this webinar, I summarize 4 main issues. The first one is private sector quality. It's uneven, so we can have in some providers, high quality services, quality of care that meet the standards, and same type of provider with kind of providing substandard health care. And this has been an issue, and also in all discussions with public sector, this comes this duality, poor care and high quality care as part of the same sector. Second is, in general, in the private sector, there is a virtual absence of QI systems. Of course, these quality improvement systems, in some of them are present, mainly in maybe large hospitals or hospitals that are pursuing accreditation, or in health facilities that are part of a social franchising or other type of association. But in the vast majority of private sector providers, they don't have, as part of their regular operations, a quality improvement system that will pursue the objective of having or delivering the quality of care that the population expects. And another element regarding quality, which is linked with this absence of systems, is that collection and information or reporting of information is often poor, and also yet another source of complaint by the public sector. The fact that one part of the private sector are not reporting or not reporting their statistics, or they are not really integral part of the system. And finally, I think users' voice is not present, or it's really not amplified regarding private sector provision. If a customer or a client, a user, have complaints, there are no mechanisms to express their dissatisfaction with private sector in general. In some countries, maybe the press, going to the press or the social media, is the only way they can kind of report quality incidents, but not in a, I would say, in a structured way. Thanks. The next, please. So what's needed? I mean, what do we need? In my view, in order to engage private sector in governing quality of care, we need to first, and probably the most important one is to have a policy environment that supports the engagement of private providers. So regulations and legislations that will make this possible from the legal viewpoint to have a positive and conducive policy environment. With this in mind, I mean, implementing this regulation and legislation will result in increased private sector integration in the health system, not just in reporting information, but also being part of important decisions that are that concerns them. Another element that is also important is the need of having an organized private sector. Governments cannot deal with on a one-to-one basis. They need to. It's much easier and most likely to succeed if government can engage with groups of providers organized in specific, private providers organized in specific ways, like social market, franchising, or provider network. We need the involvement of professional associations and scientific societies. I think this is something that I'm very pleased to see that in this particular webinar it's highlighted. This is something that needs, how do you say, a reminder. It's not a point that comes automatically in discussions, and I think this can be one of the key contributions of non-state actors to quality governance. And last but not least, by any means, it's to have an active participation of the community and users, and I would add even not just active but organized participation, ways to engage communities in a way that their voice can be listened and they can be heard. I mean, listened by not just heard, but listened by those who are making decisions, those who are providing the services, and contribute to key areas like accountability and enforcement, as we will see later on. Thanks. So what governments do in some countries and others can do, summarize here, I'm just going to very quick. First, we need a policy regime and a policy environment that is really conducive to private sector provision of quality of care. We need that governments recognize and embrace a mixed health system approach to leverage private sector, and I will explain later on, but mixed health system means a system in which public and private sector are working together. Third, quality standards and quality assessments for quality improvement that need to be in place. I think we need to have not just the standards, but a way to measure and to really have systems for quality improvement. And fourth, we need to amplify the voice of other non-state actors, and I would like to point out these two groups, I mean, provider unions, associations, and the users community, which are part of the presentations that will come this later on in this webinar. Next.
Carlos, I'm
yes.
sorry to remind you of time.
Yes, I have 2
okay.
minutes on
Thank
this.
you.
Just at the end. So we have in this slide is just to point out that the mixed health system approach what are the objectives. We want to foster networks, and also we want to engage and oversee those networks. Just want to point out that in the main interventions, there is one part that has to be with governance, which is regulation, licensing and certification, accreditation, and also all the incentives that are coming through the financing schemes and public purchase. Next. And since we mentioned this quality assessment as one important part, this slide just wants to remind the differences between or among licensure, certification, and accreditation according to the adoption policy. It's a mandatory or voluntary adoption, or the level of requirement, and to highlight that accreditation is probably the most elevated way of improving quality. It's the value is undisputed, but it requires a lot of elements that need to be developed and also will test the country readiness to go for accreditation. But I have seen it, but sometimes we call accreditation on things that are not really high level of requirement and also based in value. Next. Finally, this is a final slide, and just want to highlight what are the main areas, not the only ones, but the main areas on quality governance and standard quality assessment linked to health, financing and incentives, accountability and enforcement. And then we will have that according to countries. In some countries, each of these areas will be managed either by the government or either by the private sector, or mixed with different roles for government and private sector actors. And I believe that the involvement of users and non-state actors should be present, I would say, if not in all, in some of these areas. For instance, for professional associations, the role of their participation on quality standards and quality assessment is very important. The communities, I mean, participating in the areas of accountability and even contributing to enforcement, and I think this is just to show that we are several areas and there is a space for working together, government, private sector, and providers and other non-state actors in order to achieve our objectives. Thank you very much.
Thank you for that, Carlos. And if there are any clarificatory questions at this point, we would like to hear them. We can see a couple of questions sent through the Q&A panel. I think this would be very well answered towards the end, because this links together to presentation topics that will be given next. So if it's okay with you, Kola, we'll move on. We'll go back to you again later. We'll move on. We'll hear from Mr. Nat Otu. He will be sharing with us the use of regulatory and financing instruments in securing quality care in the private sector. Nat, to you now.
Thank you very much, Liz, and thanks everybody for being present to participate in this webinar. What I'm going to share is our little experience in Ghana in regards to how the tools of accreditation and clinical audit have been used to secure quality in Ghana's health insurance. My slides are, when you go to the next slide, the content, I have, first of all, couched the voices on the issue of healthcare quality within Ghana's health system. then accreditation as a quality governance tool, clinical audits as a mechanism for improving quality of healthcare, and finally, the emerging outlook for governance and regulation into the future. Now, I have 3 slides basically on the voices that we hear. The first one is pretty long, but the essence of it is that there are concerns and worries about the kind of quality that, the private sector gives, essentially. And I would underline this by saying that in Ghana, within the health insurance scheme, healthcare services are provided by a mixture of private and public institutions. Now, the private sector increasingly is playing a major role, and in terms of the number of accredited facilities that are offering care, they constitute close to about 40%. Now, on that note, talking about what are the problems that are, the concerns of these voices that I've talked about, the first one is about, the quality of equipment that are used, but also the quality of personnel who man these equipment, especially diagnostic services. The issues are who checks the quality of these facilities, who has oversight, and how are these responsibilities discharged. The next slide shows a very poignant statement. It says medical equipment in Ghana are inaccurate. And this is coming from somebody who works at the Ghana Standards Authority, which is quite interesting, a statement to hear from such an institution. The next slide shows us that there is general worry among stakeholders in the health sector about the proliferation of unqualified personnel in healthcare facilities. This is reported in a national daily in Ghana, and it was a combined voice of all stakeholders to say that we should get the right personnel to offer healthcare services. So generally you're seeing issues about quality of equipment, the standard of human resources, the quality of supervision, and so on. And then we go on to the next one. I think that summarizes it all. A commentator on healthcare in Ghana has said that as a country, we need to start talking openly about the quality of care that is given to patients in our hospitals and clinics, and also whether or not such patients are satisfied with that care. So that takes me to the next slide, where I outline what has happened over the period. Now, what we see is that prior to the National Health Insurance Scheme being instituted in the year 2003, there was no particular point for governing quality, especially as you try to empanel and enroll healthcare facilities to provide services. And so early on, accreditation emerged as a new mechanism for regulating healthcare services for facilities operating within the NHIS. The NHIS in 2004, because it didn't have the tools and standards to do accreditation, started a blanket ad hoc accreditation system where all public services were accredited, but private services had to go through a minimal checklist of whether they had been enrolled with the various regulatory and accreditation bodies that govern their services. Now, in 2008, in full force, the NHIS started developing tools for conducting full-fledged accreditation, and this started in earnest. And as you mentioned, the collaboration between the private and the public sector, the NHIS works, first of all, with a lot of stakeholders to develop the standards, and later on, we worked with a private sector NGO to sort of concretize some of these standards and tools and put them into an IT framework. In 2009, full-scale accreditation started, and it has become one of the most important tools for quality assurance in the health sector. The NHIS accreditation has 12 modules, and these modules cover staffing, range of services, the environment and infrastructure of the facility, organization and management of the facility, basic equipment, safety and quality, how OPD care is organized, how IPD care is organized, maternity care, specialized care, diagnostic services, pharmaceutical services. This is how the accreditation is organized. And within all these, there are sub-tools for looking at each of these headings. Now, the next one, so in the next slide, what we'll see is the outcome of accreditation within the National Health Insurance Scheme. And I'm using the year 2014. That is the one that I have most current and is full information. But as you may see, if you look at the grading and the scores of the facilities, those that scored grade A are those that are exceptional. There were only 13 facilities in the year 2014. And if you look at those that scored grade B, grade A, there was 4.6%. Most of the facilities found themselves in grades B, C, and D. And this shows that there's a lot of room for improvement. Ordinarily, it would have been very good to offer incentives for facilities to move up or to want to move up, but it has not yet happened in the NHIS, and so there are no particular incentives for facilities to want to move up. But once we display these grades, there is sort of a moral suasion for those facilities that are not doing so well to try to improve. So what we see a lot of is that some organized groups, such as the Christian Health Association, takes the results of accreditation and sits with their facilities to ensure that areas where they experience weaknesses will be improved. So that is by way of performance of the private sector in accreditation within Ghana's NHIS. I just want to mention that the accreditation has become a very important tool for also the Ghana Health Service to use to improve the quality that their providers offer. From accreditation, I'll move on to another mechanism that we use in Ghana to help improve quality, and that is what we call clinical audits or medical audits. Between the years 2003 and 2008, we did not have structured medical audits, but we started something ad hoc in 2008. Not very scientific, but it actually addressed the core problem of complaints that we received from some facilities in regard to the services they offered. And in the year 2010, clinical audits were mainstreamed to offer assurances of efficient use of resources within the NHIS. From 2010 onwards, the structure became better and better, and by the year 2013-2014, 5% of all facilities that offered care were audited for quality. But not only quality, it also has to do with adherence to all protocols in regards to the NHIS, which includes how tariffs are used and so on and so forth. Now, in order to make the results of clinical audits very acceptable, the NHIS draws on expertise from a number of stakeholders, private, public, quasi-government, and also private not-for-profit. So it's private for-profit, private not-for-profit. And the effect has been that, results have become a lot more acceptable, and it helps a lot to regulate how providers are providing care. In the process, the NHI has targeted certain conditions for attention anytime there's an audit, and one of them is how malaria is cared for and treated. And so we've been able to gather a lot of information on treatment of malaria, which is governed by strict protocols that are developed by the Ministry of Health. For the clinical audits, what we do find also is that a lot of provider groups are using the results to improve their quality. And so I have seen some provider groups, again, in particular the Christian Health Association, which takes the results of the clinical audit and tries to use that, to improve how services are given in their facilities. But apart from the issue of pure quality, there are also financial recoveries that are made, from clinical audits. And up to the end of 2015, 2016, we could enumerate about 7.5 million US dollars, which has been collected in unmerited claims. I would like to add that the USAID has seen the benefit of the clinical audits and is supporting Ghana right now to scale up clinical audits. So it's taking audits from 5% to 7.5% as of the end of 2016, and there is every promise that it could be expanded furthermore into the future. The clinical audits, apart from recovering money, have also led to disaccreditation or downgrading of facilities that do not meet the standards that are required of them. Now, so the next slide shows the areas of focus of NHIS clinical audits. About half of the areas are clearly quality related. For example, so if you look at the beginning, there is wrongful application of service tariffs, which is financial, but then you have non-adherence to clinical treatment guidelines and protocols, inappropriate medical documentation, incomplete medical notes, and you can see the list as it goes down. And some of these really actually lead us to disaccredit facilities when we find out that the infractions are quite major. So the next slide shows that from the inception of the NHIS, there has been an impetus to improve quality, and the discussion has been going on now very vibrantly in the sense that the stakeholders now in the sphere have become stronger and more numerous. So civil society is involved, the NHI is involved, and this has led currently to a new development in Ghana where the Ministry of Health has started a process of developing a comprehensive health quality strategy. There are 4 pillars so far for that strategy. The first is institutional coordination and policy rationalization. And I'll underscore this a little bit. You find out that in the ministry there are quality policies that sometimes are in conflict with each other. So these are going to be rationalized. And secondly, the roles of the various institutions in governing quality is somewhat not really well defined. So that's also going to happen. The next is to look at what are the outcomes in priority areas that are being set out by the Ministry of Health to be impacted by policy. The third is placing the patient at the center of care and to give the patient a voice. And in this, we also see the function of civil society to come in and actually be part of the discussion as regards how quality can be improved. Next, we have strengthening of regulations and accountability processes. Indeed, the accreditation process of the National Health Insurance Scheme gave rise to a new legislation in 2011 in Ghana called the Health Facilities Regulatory Act. This came about because there was the realization that there was the need to strengthen regulation as far as registration and licensing of facilities were concerned. The NHIS now relies on that license as a basic requirement for taking any facility through the accreditation process. And again, this same law also makes provision for a process of accountability where facilities are required to submit information, not as far as an administrative process, but as a legal requirement. So in a nutshell, this is how accreditation and using of financing instruments have played a role in securing quality in Ghana's health insurance scheme. I will be open to take questions during the question and answer session. Thank you very much.
Thank you for that, Nat. I can see a couple of just clarifying questions. We'll reserve the others for the Q&A, but if you can just give an indication of how large the informal sector or the private providers in Ghana, and are they engaged in enforcing, developing and enforcing the policy? I think those are just the 2 questions that I'll pick up from the questions that we have received so far. There are a lot more for you at the end, Nat. So just those 2 for now. Thank you.
Can I go on, Lisa?
Go ahead, Nat. Thank you.
Okay. So close to about 40% of the services are provided by the private sector in Ghana. In regards to regulation, what we are seeing a lot of now is because of the processes of accreditation that exist, there's a lot more self-regulation. And this self-regulation really is, done in preparation, for the accreditation process. That same thing happens in the area of clinical audits as well. In the area of developing regulation, as I said, there's a lot more involvement of civil society and the private sector in this process.
Okay, thank you for that, Nat. There are also other questions on capacity building in doing accreditation. We'll go into that during the Q&A. So moving on, Dr. Raul Killiamore will share with us his insights on the medical societies, particularly the Society of Obstetrics and Gynecology's input in Quality Assurance Committee, a collegial body that provides policy recommendations to PhilHealth. Dr. Killiamore, to you now.
Thank the give insights on the role of society in strengthening the governance of quality. And I understand that I was invited here, being part of being a member of the Quality Assurance Committee of PhilHealth. But at the onset, give a brief description of what PhilHealth is to our participants. PhilHealth is actually the Philippine Health Insurance Corporation, so it's short as PhilHealth, and it's a government-owned, established in 1995, and this functions under the umbrella of the Department of Health and was mandated to implement the National Health Insurance Program of the Philippines. Can I have the next slide? Okay, thank you. So, part of the function of PhilHealth, part of the mandate of PhilHealth was to create the Quality Assurance Committee, and this was actually mandated by Republic Act, by the implementing rules and regulations of Republic Act 7875 of the National Health Insurance Act of 1995, which was subsequently amended by two Republic Acts. And the objective of creating the Quality Assurance Committee was to achieve the objectives of the monitoring activities shall include the peer review. So, regarding the evolution of the Quality Assurance Committee, we can see on this slide that it actually started in 1999, where we have the Relative Value Oversight Committee, established in 1999. However, this was not renewed and resulted in other issues related to relative value scale. This problem when in 2008 there was an integration of the functions of these two oversight committees, so were consolidated in the Quality Assurance Committee in 2008, years before integration of the two functions, the functions of these two oversight committees. Can we move to the next slide, please? Quality Assurance Committee functions and want to assist in the development of the policy of the corporation on performance or for the accredited providers, particularly on the peer review is in its role. Another function would be to assist in the resolving technical issues encountered in claims processing as well as the monitoring of performance, to assess the quality of practice behavior of healthcare providers, HCPs, and come up with recommendations or solutions to resolve issues related to such activity, and also the adoption of the mechanisms and tools such as utilization review and the assessment of outcomes. It was also tasked to promote the development and use of clinical practice guidelines, or CPGs, or clinical pathways, which we still use at present, and other acceptable standards of quality care based on best available evidence. So this is actually evidence-based activity. Also to apply the information derived from its activities, including the development and adoption of standards of care for the promotion of quality in Philippine healthcare settings. Okay, so who compose the Quality Assurance Committee? We have two groups, one coming from outside, we call them the external experts, and another one from within the corporation or the internal members of the Quality Assurance Committee. As we can see in this slide, there's a list of the external experts here, and foremost in the list is the Philippine Hospital Association and the Philippine Regulation Commission. The Philippine Hospital Association is actually a group of hospitals grouped together, and the Professional Regulation Commission is actually the licensing arm of the government in terms of giving licenses to medical, not only to doctors but also to other professional groups like engineers, nurses, etc. And then we have the Philippine Medical Association. This is not a government agency. This is a group of doctors, specialists, and the non-specialists. And then from number 4 down to number 10, we have here a group of specialist societies. So we have the Philippine College of Surgeons, College of Physicians, the Philippine Obstetrical and Gynecological Society, to which I belong, the Philippine Pediatric Society, Philippine Society of Anesthesiologists, Philippine Academy of Family Physicians, and the Philippine Academy of Ophthalmology. And members coming from the external experts receive honorarium for each meeting of the Quality Assurance Committee. And then we have the internal members of the Quality Assurance Committee, and this includes the Senior Vice President of the Health Finance Policy Sector, the QAC he also serves as the QAC Chairperson. We have the Group Vice President of the Quality Assurance Group, the Senior Manager of the Benefits Development Research Department, the Senior Manager for Accreditation Department, the Senior Manager of the Finding Investigation and Enforcement Department, and the Senior Manager of the Standards and Monitoring Department, which incidentally also serves as the Secretariat of the Quality Assurance Committee. All of the external experts or external representatives of the QAC and the head of the Health Finance Policy Sector are voting members. All other internal members are non-voting members. So, can I have the next slide? Okay, so complete staff work is important in getting the details regarding a case, and this ranges from reviewing the hospital record of the patients, getting information from PhilHealth Regional Office, and interviewing the patient if necessary. And as we can see in this slide, we have the pre-Quality Assurance Committee meeting wherein the committee receives the patient complaint, and then the committee gathers data regarding the complaint of the patient, and then after the data gathering, we do complete staff work, and then the Quality Assurance Committee meeting takes place, wherein the case is being presented, and we get experts' opinions, and then we deliberate on the case and come up with agreements on what solutions we want to undertake, and then the Quality Assurance Committee comes up with outputs and resolution. The PhilHealth Regional Offices, because we have this different regional offices all over the country. The information is being relayed to them, and also the patient, it needs to be informed. And we also come up with policy adjustment or amendments in the existing policies if necessary. Okay, so the big question now is how does specialty societies contribute to governance of quality? And I belong to the Philippine Obstetrical and Gynecological Society, and I had the opportunity of serving as president in 2013. And incidentally, it was also that year that I was a member of the Quality Assurance Committee of the Philippine Health Insurance Corporation. And so, for example, in the case of the Philippine Obstetrical and Gynecological Society representation in the Philippine Health Insurance Corporation, the task that was given to me, and I remember this case very well. We have this case presented to the Quality Assurance Committee, and this was a case of a 25-year-old primigravid. This was her first pregnancy and delivery. She was actually delivered by cesarean section due to arrest of labor or prolonged labor, and after delivery, by cesarean section, she had uterine atony and she had profuse hemorrhage. So she underwent a total abdominal hysterectomy. However, post-operatively, I think it was within the day, the patient expired post-operatively. And we know for a fact that delivery, either by cesarean section or by normal delivery, nobody should, or no woman should die giving birth, and this is actually a preventable case. So this was reviewed in the Quality Assurance Committee, and I had the opportunity to evaluate and analyze such case. So the Standards and Monitoring Department gets complaints from PhilHealth members about the quality of care they receive, and this is presented to the QAC and is assigned to a representative of the Specialty Society to comment, to evaluate and give his comments in address regarding the issue. Can I have the next slide, please? Okay. So another case that was brought about during the discussion was the deliberation on visual inspection with acetic acid. We call that BIA. So we inspect the cervix using, or by coating the cervix with acetic acid, and questionable areas, say for example, the pale areas within the cervix are subjected to a biopsy. So the field sees the potential of low-cost cervical cancer screening, or the BIA, as a compensable procedure. And actually, we are now doing this, and this is being compensated already by the Philippine Health Insurance Corporation. And here we can see that the BIA is being performed, and the QAC deliberated on the merits of this screening program, and we give insights to the cervical cancer program, who are qualified to perform the BIA and where can this be performed. So we have settled the issue that BIA can be performed in an outpatient basis. It can be done in the rural health clinics as long as the healthcare providers are properly trained. And then as an output of the Quality Assurance Quality Assurance Committee, it was recommended to use the clinical practice guidelines on cervical cancer for crafting the policy statement, and then we convened with concerned specialty societies for RVU so that it can be compensated. For example, the performance of cryotherapy. This is a therapeutic measure wherein we already do cryotherapy in cases or in services wherein we see the pale areas, and instead of doing the biopsy, we go directly to doing a cryotherapy. Okay, so as far as the specialty societies are concerned, so specifically the Philippine Obstetrical and Gynecological Society, we contribute to the governance of quality by making sure that the members of the society, of the specialty society, are compliant to the approved and updated management protocols of the clinical practice guidelines. So from time to time, every 1 or 2 years, if there are new updates regarding the management, the diagnostic procedures and management of a particular obstetrical or gynecological problem, we update this, and the Philippine OBGYN Society tasks a particular or a specific committee to do the job. And then we also hold discussions on current peer practices related to delivery of care, which may need to be addressed by enhancement of current policies. Consultations are being done on how doctors would want to be apportioned, the professional fee of period reimbursement be distributed among HCPs to handle the case. And these are actually ongoing. And the Philippine Society of Obstetrics and Gynecology and also the other societies are made to police their own ranks by creating audit committees or audit boards. And in fact, we have the ethics committee also in the different society because it is already required. And we also update our knowledge by attending continuing medical education activities. So we have postgraduate courses that we are required to attend. We also have the annual conventions and the mid-year conventions, and all the different societies also have these activities. We also have the newly formed Academy of Medicine of the Philippines, and this is actually an association of the different specialty and subspecialty societies in the medical profession in the Philippines. And the AMP, as part of its primary function, tries to standardize basic requirements of training programs. So it doesn't matter whether you are an obstetrician, you're training for an obstetrics and gynecology or surgery. We establish, now we are in the process of establishing the basic requirements, and the secondary or the tertiary requirements are actually left to the different specialty societies to form. And then we in our society, we also have, as I mentioned a while ago, the audit committees. The Philippine Board of Obstetrics and Gynecology and the Philippine Obstetrical and Gynecological Society require all accredited hospitals to have their own audit and ethics committee. And then within the different regions or areas of the Philippines, we have the regional societies or the regional branches who also take care of this problem or this concern in the regional level, and then the highest level is the Philippine OBGYN Society, and even the Philippine Medical Association also have their ethics committee to police all the different subspecialty, specialty, and general practice doctors. So all of these are being taken into consideration so that the medical profession in general will be able to contribute in their own, well, we call it little way or small way, or whatever efforts we can give to make our contribution also palpable and felt by the government. And we also want to, we also have, even in our training program, even in the residency training program, we also have we also have quality assurance committees to make sure that the residents get a standardized training in the different parts of the Philippines. So I think that's about all about my presentation, and if there are questions later on, then we can discuss them. Thank you very much.
Thank you so much for that, Dr. Raul. And yes, we will get back to you for questions.
Yes.
But for now, let's call on Paulina to walk us through about the collecting citizens' voices, no, in informing and improving the quality of care in Mexico. To you now, Paulina.
Thank you. Good morning, everyone. Can you hear me?
Very well.
Okay.
Go ahead.
Thank you. Well, I am very honored to share an example of the Mexican experience where non-state actors are involved in the improvement of quality of healthcare. So in this occasion, I will talk about a mechanism called Aval Ciudadano. Next, please. Well, first of all, it is important to know exactly of what are we talking about and why it was created. We were in a context where the patients, their families, and in general the population didn't trust the healthcare institutions. So all the efforts done to improve the quality of healthcare didn't have an impact on the perception of the people. It was very important to find a way to recover their confidence. So since 2001 was created a figure known as Aval Ciudadano, that in English means something like citizens endorsement, something like that. It is a mechanism of citizen participation that endorses the actions of perceived quality and dignified treatment provided by the health institutions in order to contribute for the improvement. In an independent and responsible way, this mechanism takes part on the evaluation of the health services, helping the institutions to increase the confidence the users have on them. The Avales Ciudadanos are a link, the previous slide, well, okay. The Avales Ciudadanos are a link between institutions and users of health services through the participation of civil society. So which are the objectives of this mechanism? In general, the objective is to promote citizen participation on the evaluation and improvement of quality on healthcare services. In a more specific way, the Avales Ciudadanos identify needs and expectations of quality improvements, generate transparency of the information and results, participate with authorities and health personnel in decision-making, increase the confidence of patients and citizenship in health institutions. They help us also to spread information to users of health services and generate new initiatives that promote a broader participation of citizens in order to achieve optimal quality of health services. Next, please. There are no limitations to participate as an Aval Ciudadano, as long as there is a commitment with the improvement of quality of healthcare at the community. So, civil organizations, academic institutions, private companies, other groups, and individual citizens can be an Aval Ciudadano, as long as they have representativeness, prestige, and credibility among the population. So, until last December, our national health system had 14,798 Avales Ciudadanos along the 32 states of the country in the national health system. So, as we can see in the graphic, most of them are individual citizens. Every Aval Ciudadano must adhere to a code of conduct, which consists of 10 points that promote the performance of an objective work, avoiding conflicts of interest, and honoring the designation. According to the code of action, an Aval Ciudadano can be categorized as local, municipal, jurisdictional, or delegational, or statewide. And depending on that is the level of responsibility that they acquire. The process of convening and selecting the Aval Ciudadano begins with a public call made by the state authorities. There is also the option to direct invitation to organizations or individuals. So then the process ends with the formal installation through an act. The Installation Act is the document that formalizes the beginning of operations of the Aval Ciudadano in a healthcare establishment. Their data gets registered in a system created for this purpose, and they receive a credential that credits them as such. Also, it's important to mention that the period of action of an Aval Ciudadano is defined by the medical unit and by the Aval. However, it is recommended that its period of action is at least 1 year to achieve certain continuity. Next, please. Some of their principal functions are listed in the slide. First, they apply perception surveys to users in order to know the opinion regarding the attention received. They collect suggestions from users to improve the quality of care. Also, review the conditions of waiting rooms, restrooms, and consulting rooms. Make proposals for improvement. Disseminate rights and responsibilities of patients. Follow up letters of commitment made by the heads of quality of the medical institutions regarding the suggestions issued by the Aval Ciudadano. A letter of commitment is a document that is formulated after the detailed analysis carried out by the Aval Ciudadano, which includes the demands of the users and can be fulfilled by the medical unit. They also participate in the Patient Quality and Safety Committee and participate in the accreditation process whereby the establishments receive funding. Next, please. So, summing up, every healthcare establishment has an Aval Ciudadano that facilitates the linkage between the users and the healthcare providers. Also, every Aval Ciudadano has a close relationship with the responsible of quality at the state level, also known as REC. It's the man included in the slide. One of the most important functions of the responsible of quality at state level within Aval Ciudadano strategy is the coordination of training for them in relation to the importance and operation of the mechanism. Also, the 32 RECs, one for each stage of the country, are the link between the states and the federation. In this case, the federation is represented by the General Directorate for Quality of Healthcare and Education of the Ministry of Health. That's where I work. And it helps us to know what is going on at the state levels and act in consequence. Next, please. I will also share with you some results of this mechanism. For example, since 2009, more than 130,000 letters of commitment have been signed, of which more than 50% of them have been attended. Most of the improvement suggestions issued by Aval Ciudadanos refer to the provision of medicine, almost 3%, followed by the conditions of the facilities and waiting times with 15% each. They also issue recommendations related to the perceived quality of patient care, as well as access to information. Also, thanks to the participation of Aval Ciudadanos, there are cases where the federal government have identified areas that can be improved in terms of resource management process between the healthcare establishments and local authorities, the need to remodel or expand medical facilities, or to improve quality of healthcare in specific areas. Another example is that as part of the joint work between the health system and Aval Ciudadanos, two organizations proposed the creation of the Decalogue, Rights and Responsibilities of Patients. This proposal was approved by the General Directorate for Quality of Healthcare and Education in 2012, and since then, this Decalogue is disseminated at the healthcare facilities to inform users. Next, please. Finally, I can tell you that there are aspects that can be improved. For instance, we consider important to achieve a greater participation of the academy and civil society organizations, since the great majority, as you saw, of Aval Ciudadanos are individual citizens. But there is not much interest to participate since the activity does not imply an economic remuneration. So we are thinking about options to deal with that. Thank you very much for your attention.
Thank you for that, Paulina. And previously, we received clarificatory questions for Carlos. Before we go into discussing all the other questions, perhaps we'd go back to have that clarification at this time. Carlos, the question is, can you expound or clarify the concept of governance areas that you have presented in, I think, in your last slide, please? Thank you.
Yes. I think that's let me open. Can you put the slide back, or would be much of a problem? So in the last slide, is this back on screen? Yeah, thanks. In this slide, what I was trying to communicate that there are some key areas in order to operationalize governance. And these are not the only ones, there are others, but I tried to select those who are more relevant. And these areas are quality standards in the sense of who define these quality standards, what's the institution or what is the mechanism to define what are those quality standards. And this is I believe it's a very, very important point. And second is how you measure. What are the approaches to measure these standards for both facilities and providers? And we discuss about in this area, for instance, that we going towards accreditation, it's licensing a requirement. Are we going to have something in between, which is certification? I think all of this, how we're going to measure this quality. Then the issue of linking to health financing and incentives, especially for private sector, but also for public, the fact of having some incentives or motivations to that can strengthen their commitment to produce quality. Then the need of having an accountability framework in the sense of who's responsible or how can we make people accountable for their actions, and then the enforcement of these quality standards in case facilities or professional or individual providers are not really complying with standards, and it might include even the let's say the need of having more kind of strict or corrective measures in case of let's say malpractice. So these areas I believe are very important, and one of the key elements in governance is who is going to manage this, who's going to be on the leading part or the decision. And then we have a spectrum of possibilities for, if we pick one like quality standard, is this government, Ministry of Health or whoever is the government institution that will define on their own what are the standards that all providers should follow, or on the other hand, you have if the government will delegate this authority to the private sector, for instance, in the case of, because we are talking about engagement of private sector, or for instance, if the scientific societies or the specialty societies have a voice on this, can they be in charge of drafting the standards that would be approved probably by the government? And I don't mean to kind of substitute one for the other, but by another, but to do it together, or to have a mixed approach, which in most cases seems to be the most reasonable way of working together. And when I say mixed, it's public sector, public and private sector, and other elements of as well.
Thank you for that, Carlos. And connected to what you just mentioned, no, there was this question. I think this is directed to you, no, that how do you encourage owners of the health facilities to become part of organized or associations of professionals, no? Because from the perspective of COLA, the one who asked this question, it would be easier for the government to engage the private sector if they are part of the association. What do you say about that, Nat?
Yeah, thank you very much, Lizo. It's a very relevant question, and I probably didn't mention it in my presentation. But in Ghana, following the onset of the health insurance, there's been quite a movement on the part of the private sector. So there are two private sector associations, actually three now. The first was the Society of Dental and Medical Practitioners. The second became a Health Insurance Providers Association. And the third became a Pharmaceutical Chamber, which all came to deal with the health insurance as far as quality was concerned. So when it comes to the issue of quality, especially accreditation, these three bodies actually have a say in how this is conducted and the feedback that we get from the field, how it feeds into their work. So, for example, the private medical and dental practitioners hold CPD programs for their members based on some quality aspects of the NHIS, of course, in addition to other things that they like to train their members on. So a body of, a movement has crystallized around quality, where, in fact, the private sector itself is actually warming up to the need to up and improve quality in the provisioning of healthcare to members of the health insurance scheme, for a start, and secondly, to patients in general.
It's interesting. Thank you for that, Matt. It's interesting that the response from the private sector is positive, but there is also another question here about how could a weak public sector providing poor quality services regulate the quality of care in the private sector? That's a very interesting question that I hope you can, share your thoughts on with us.
Lisa, this is a question that we always hear from the private sector, and to the effect that some, practitioners in the private sector really sometimes question the capacity of the public sector to govern. But what has been done since the health insurance accreditation came is the development of new regulatory regime, which now requires both public and private sector facilities to be licensed and regulated. So to start with, the regime where the public sector was excluded from regulation is gone in Ghana, and the public sector is now susceptible to regulation by a regulatory body. And you asked the question, right, has that regulatory body got the capacity to now tackle this big task that is given it? It's a challenge, and so far in Ghana, we are working at it to build the capacity of this institution, which we call the Health Facilities Regulatory Institution. It is meant to be an independent body, completely removed from the Ghana Health Services. But as has been said again, the issue of giving it capacity has become a challenge. But I would believe that it's the starting point of regulation, and a lot of attention is being paid to it right now.
So just to clarify on the capacity, I was told we only have 3 minutes left. I wish we could have more time to discuss on Ghana's case, no? But there's a question for Dr. Killiamore on how do private or provider associations develop their capacity nationally and regionally. How do they raise income, increase human resource and financial capacity, and in general their programming abilities. And before I give the time to Dr. Raul, I would also mention the question for Paulina. What is the financial mechanism for the Aval Ciudadano who funds the individuals or societies that do this work? Although you mentioned that in your presentation, Paulina, maybe you would like to share with us how are you going to move forward with this question, no? So to Dr. Killiamore and then to Paulina. Go ahead, Dr. Q. Is Dr. Killiamore still on the line?
Yes. I'm asking you if you would be kind enough to repeat the question for me, because I wasn't able to understand that question very well.
Oh, I'm sorry. So
yeah.
Okay. All right. Actually, you have two questions here, but let me just go back to the question that I mentioned. How do you increase your capacity, both regionally and nationally, in terms of human resource, in terms of financial capacity, no, as a specialist society?
Okay. I have mentioned a while ago that the Philippine Obstetrical and Gynecological Society has a national office, and then spread around the different parts of the Philippines. We have the regional societies of the Philippine Obstetrical and Gynecological Society. And every year we graduate a lot of residents, more than 100 of them every year. And so this adds up to the membership of the society. The different regional societies are actually independent in terms of their financial capacity, because they have several activities to generate income for the region, so that this can address all the different activities that they want to undertake in the region. So in terms of human resource, we really don't have a problem about that, because we do get new members every year, and as the members add up in the different regions, then that follows that the region will also have a higher income in terms of membership fees and other activities that they do. Like, for example, they organize postgraduate courses and other income generating activities. So it's actually not a problem in the Philippine Obstetrical Society, and I'm speaking not only for the Philippine Obstetrical and Gynecological Society, but the other specialty societies in the different regions of the Philippines. So did I answer that question, Lizelle?
Yeah, I think you did. Yes, I think you did, Dr. Q.
Yeah. Okay.
And maybe, yes, and maybe call on Paulina for the question on Aval Ciudadano.
Yeah, thank you, Lizelle. Well, there is no remuneration for the Aval Ciudadanos. It's an activity carried out free of charge by people interested in improving the quality of the health institutions. Thank you.
Thank you once again, everyone. I think there are other questions that we have not replied to. Do we have another question for Paulina? Oh, okay. Okay. This question is actually for all of you. The quality of care is a continuous process. It needs human and financial resources. What actions are especially recommended to promote quality of care? I think if I could ask 1 or 2, 3 sentences from our panelists, starting with Paulina. Paulina?
Yes, I'm here. Well, in Mexico, our strategy includes three important things. First of all, the regulation through the accreditation process. Second, the quality of healthcare in terms of citizen participation, in terms of quality model that is implemented in all our healthcare units, and also very important, the human resources capacities. So we work hard on that. That's my answer. Thank you.
Thank you for that. Dr. Kilia Moore. Okay, may we call on Nat? Nat, are you still on the line?
I probably would start from a very different angle. I would say that quality really is an issue of culture. And so what is important is to, to give birth to that culture and to nurture it. Without that culture, financial resources, human resources, and all the policies will not really give us what we want. But certainly, a good regulatory environment is a must. Secondly, the human resources and the capacity to develop and to follow up quality is also important. And finally, the important thing is how to get reports out of our healthcare providers so that we can have a more objective way of looking at quality.
Like other panelists who are willing to share their emails, they can be reached directly by our participants. And Dr. Carlos?
Yeah, what I would like to say is, my answer is that we need policy environment in which the culture that Mr. Otto mentioned can really develop the results. So culture is very, very important, and to foster this culture, to create the environment, it's certainly a governance role, and part of this culture is to make providers and the health system as a whole to listen to the users, to the citizens that are the ones that are not just expecting to receive the services, but they are an active participants. Thanks.
Thank you so much, everyone. Again, for the questions that are left unanswered, we'll try to share that with you, the answers to that with you as well. No? And on behalf of our team from Associates and Joint Learning Network, we thank our panelists today as well as our participants for joining us in this webinar. We will sending you the presentations used in the webinar and within 24 hours, and the recording after a week's time. We would also like to request your feedback by answering the survey that you will receive along with the presentation. This is to help us improve our next webinar. Good morning, good afternoon, good evening, wherever you may be. Thank you. Thank you once again.
Thank you very much.
Naka-mute pala ako. Sus.